This is Sg2 Perspectives, a conversation with industry experts and Sg2 thought leaders about the biggest trends in healthcare and what we all expect that's going to mean for the future of healthcare delivery.
Very interesting opportunity here, and it has to balance with being quick just for the sake of being quick versus being quick and trusted by your patients and your physicians and really the broader community.
Hello and welcome to Sg2 Perspectives. I'm your host, Kelly Richard. Today, I will be talking with Brian Esser, Associate Principal on our Enterprise Strategy Intelligence team, and Ryota Terada, Director of the Orthopedic Service Line. Brian and Ryota have been leading our work modeling the reactivation of elective surgeries post-COVID-19. I'll be picking their brains on the approach for health systems ramping these services back up in the coming weeks and months. Thank you both for joining me today.
Thanks for having us, Kelly.
Thank you, Kelly.
So just to set a little bit of the stage and context here, when COVID-19 emerged as a crisis, most health systems halted all elective procedures to ensure appropriate capacity to treat the critically ill COVID-19 patients that they expect to be coming in. However, because the hospitals draw most of their margin from elective procedures, many are seeing catastrophic revenue losses and margin compression. So in conversations that we're having with CFOs and strategy teams across the country, we are already hearing about the strategies they're starting to develop to reactivate elective surgeries and diagnostics. And they're doing this both to keep their doors open as well as to serve the backlog of patients currently delaying care. So if I'm a healthcare executive, perhaps a CFO or CSO at a health system, at this point, we've been all hands on deck in responding to this crisis, and now I'm taking a breath. Every day I'm looking at a negative balance sheet and a backlog of patients needing care. What are the initial considerations that I need to keep in mind as I approach reactivation of elective services?
Yeah, Kelly, and it's Brian, and that is probably the number one question that Ryota and I have been receiving for the past at least 2 weeks, if not longer. Because I think every health system executive recognizes the necessity of shutting down to conserve PP&E, get their beds freed up, and really prepare for the surge, or at least the theoretical surge of COVID patients. But now that we're somewhat post those surges in some markets, or in some markets it never even really occurred, they're quickly saying, I need to get back to as normal of operations as possible, recognizing that we are maybe in a brand new normal moving forward. We've been really rallying this around three major topical areas. And the first being testing capacity. And the reality is that if you want to get back to operations, you need to understand the prevalence of the virus in your market and have plans in place to rapidly and actively identify who's infected, working in conjunction with your public health entities, as well as maybe the academics in your market, thinking about how do we ramp up testing so you can get a handle on it and really contain the virus at a global population level. But then also, as you're beginning to bring on elective surgeries and think about running patients through your ORs, how do you ensure that those patients don't come in positive for COVID and you don't expose your workforce? So testing is your number one sort of key focus area at the moment. But that's also quickly followed, or maybe a 1A, is defining what are the rate limiters that will prevent you from getting back to full operations. And those can be everything from PPE and just a lack thereof, but more generally supplies, surgical supplies, medications, anesthesia, you name it, all that needs to be accounted for. And also the workforce and facility constraints. Both of those, the workforce obviously very tired and exhausted. Are they ready and willing to either ramp back up or come back from furlough in a quick way? In your facilities, do you have the ORs ready to go, but also the beds within the facilities to handle these patients post-op, as well as the post-acute side? And then lastly, the system of care. That's your sort of major bucket, because it's not just your facility. It's engaging your primary care, your virtual health situation to ensure that pre-op sort of protocols are in place and your pre-op testing is ready to go, inclusive of COVID testing, and also post-op and your post-acute. Can you limit the overall discharge to SNFs and really ramp up the home health coupled with remote patient monitoring to make this as effective as possible? With the ultimate goal at the end of the day, Kelly, and Ryota, I'm sure you would agree, you need to create a safe environment for patients moving forward. And those organizations that are focused on creating a safe environment where they're trusted by the patient base will return in a much quicker and more sustainable fashion moving forward.
Mm-hmm. Totally agree, Brian.
So these three main areas of focus, testing, workforce, and a supporting system of care, all of these are on the supply side, focused on whether the health system can provide services. And you start to get into this a little bit when you talk about patient trust, but what about the demand side? Even if health systems have the capacity for elective procedures, will patients be ready to come back into the hospital setting to have them?
Yeah. The supply side at the end of the day is easier to get our hands around because there's certain things that the systems can at least actively work on, thinking about how do we manage our workforce effectively? How do we repair our facilities to handle this, working with facility operations? What are our supply channels and what do those look like? And what can we do to get ahead of that? The demand is a bit more fuzzy at the end of the day because patients and understanding where they're at mentally, and even, we've seen a huge dip in patients showing up for stroke and heart attacks. So there's a lot of patient fear and reticence out there, and demand is just harder to gauge. Ryota, what would you say about the demand side?
I think, Kelly, you're bringing up an excellent point here. It's something that we definitely don't want to diminish the importance of it, but something that you want to probably monitor and react to in real time, as well as something that you can think through how you could potentially influence it. Certainly, we're thinking about, how do we make a safe environment for patients, but how do you communicate that? How do you really gain their trust? I think there's quite a few health systems that are thinking, how do we get that feedback and reaching out to their patient and family advisory councils? But this will be definitely a critical thing for them to think through.
Right. And the ability to communicate is really dependent on having a plan in place for whatever scenario plays out. I've seen the financial calculator that the two of you are working on, and it appears to be based on 3 high-level scenarios or curves. Can you talk through those?
Certainly, Kelly. When we're thinking through kind of this reactivation and how does that look going forward for the recovery, there's a lot of unknowns. And as we look at the kind of epidemiological models, as well as what's in the prevailing literature, we came upon 3 prevalent scenarios that we wanted to help our clients model. So this is kind of those letter-shaped models of V, U, and W. V shape being probably the most optimistic and unfortunately looking less likely, where you are able to restart surgery, ramp up fairly quickly, and not have too many bumps along the road. All the considerations that Brian mentioned around testing, supply, workforce can be addressed and controlled for. That's not looking as likely. So that's where kind of that U-shaped curve comes in, where yes, you may be able to restart, but that ramp up period, it's going to have a few bumps in the road. It's going to take quite a bit of time to get that kind of supply side working, let alone kind of the demand constraints. And finally, as we're looking at hearing from our experts tracking kind of the COVID-19 trends, it's more and more likely that we're going to see a resurgence of COVID-19 cases, at least in local and regional levels, which might lead to a secondary postponement. So thinking through what that impact will have on your system. And one critical thing about thinking through all these scenarios is, what does this mean for kind of the pace of recovery and the pace of the resources that you bring on as you think through what this recovery looks like?
And just a quick follow-up question there, when you're talking about these curves, do they represent volume of cases, revenue, margin, all of the above? What are you usually tracking when you're creating a plan like this?
All the above, but for separate reasons. Cases definitely have an implication for kind of the operational workforce supply constraints, revenue and margin, because as you mentioned at the beginning of this podcast, really the financial situation is catastrophic for many organizations. So you have to keep an eye on how do you kind of face or mitigate the dwindling cash on hand from the revenue side, as well as thinking through, well, what can you do to ramp up while also keeping an eye on cost increases for your margin as well.
So the 3 curves that we have here, as Ryota said, the V shape is probably highly optimistic from what we're seeing elsewhere. The W shape is probably becoming the most likely scenario, just seeing the resurgence in countries that are ahead of us time-wise with the virus, and then linking that to recovery in volumes and associated revenue and contribution margin. So that's our thinking on that, but obviously it's changing day to day and will continue to evolve as we move forward.
And as a health system, once you have an idea of a likely scenario, and I'm sure that those curves will vary a little bit across markets, but I agree with you. It looks like at this point that W-shaped curve is likely in most markets. What are the types of decisions that model is informing for your reactivation process?
It's really thinking about, especially in the reactivation phase. And, as of today, we're starting to see states either say we're ready or we're a week or 2 out from being ready to go. So it's starting to think, okay, what can we actually influence from the hospital side and what plans can we put in place? A lot of CEOs and others have put their task force together And these task forces are everything from operations to HR to facilities. So a fairly multi-pronged group of folks thinking about this. But really the idea of how do we get our ORs ready? Can we actually do that well? What workforce considerations do we need to factor in given the exhaustion and or the situation under furlough? What kind of capacity constraints do we have on the beds or the ICUs? And then even more broadly, how do we begin to engage with our physician base? Some have large employed groups, others have independents. So there's a lot of communication going on between the hospitals and the physicians to help get surgical schedules lined up without a true start date. How do we get our testing protocols and pre-op going? How do you get pre-auths through the insurers lined up in an effective manner? Are you communicating well with them? So there's a lot of those sort of operational nuances that have to begin now with maybe a lack of clarity on the certain start date that could be forthcoming.
Got it. Yeah. So the start date is probably one of those levers that they're going to pull. Ryota, what are some of the other key levers that a health system can pull here to, sort of start and stop and move at a different pace when they're ramping back up?
A couple considerations here. First, while we've been speaking kind of globally about the shapes V, U, W, the other consideration is tiering the recovery. So thinking through what comes back first, what can come back first, both from a clinical standpoint as well as kind of the resource constraints that Brian went through. So I think ultimately, with weighing both of those considerations, if you can make a system that lets you get out of the way of surgeons, that's the best. But how do you do that? How do you really support them? All the considerations that Brian mentioned are going to be critical. But which one you pull at what speed and when to pull it is going to differ by each organization.
That makes sense. And I would wonder too, in this, we're kind of, getting away a little bit here from just looking at an individual organization, but when we look at the overall market, do you think that an organization's ability to ramp up more quickly or smoothly could change the market landscape? Is there an opportunity here as an organization that may be in second place to move into first place in terms of market position because they've been able to handle this process of getting back online more quickly?
Yeah, Kelly, I think there's a very interesting opportunity here, and it has to balance with being quick just for the sake of being quick versus being quick and trusted by your patients and your physicians and really the broader community. So just ramping up to ramp up and say we threw our doors open, we're open for business is one thing, but to ramp up in a way that you have done solid planning and is sustainable and reflects the reality that the virus may come back, and to know what you will do in that scenario as well is really where the ones that are ready to take the leap ahead will do so. In markets where there's multiple competitors, understanding how you're positioned, how you're perceived is going to be key. And then additionally, if you have, several facilities or your regional provider, now is the opportunity. And we're hearing this from some of our more advanced organizations of, hey, we want to do some service redistribution. We want to change the way we're operating. Those kind of opportunities exist right now, but probably only for the next 3 to 4 weeks. So if you want to do that now, the planning and sort of implementation of that needs to happen in a meaningful way, real time.
Yeah, it sounds like you're essentially creating a clean slate in a way that you might not normally have the opportunity to do. So if we want to look at a silver lining here, there's one there.
Yeah, for sure.
So given that there, has been a huge reduction in these elective services and it's been so financially devastating, can you think of any lessons that are being learned throughout this crisis to help mitigate losses in future crises?
In many ways, I think this COVID-19 pandemic experience has been a preview of the future. Not that we're going to always live in a pandemic, but more that we've recognized in the US that our healthcare industry relies on an unsustainable model. We've certainly tried to move to value-based care and other kind of alternative payment systems, but in a very acute time frame, we are highlighting the reliance we have on cost shifting, commercial payment, really performing more elective services in order to be able to support the other missions of the health system. Hopefully, this experience channeled appropriately can be a catalyst to lay the foundation to succeed, but would really be interested in yours and Brian's thoughts.
Yeah. And Brian, you and I have worked so much here on value-based care. And the way that I'm sort of seeing it to a degree is part of this is a cash flow issue. The organizations that are very dependent on fee for service, and the physicians that are working for RVUs are experiencing a tremendous loss right now. And there's a lack of stability there for the overall organizations versus if you see organizations with capitation agreements, as well as those like Maryland, for example, the state has a global budget. They're in a much more stable financial position as a result of that, having those prospective payments from a cash flow perspective. So I'm wondering, could this be the catalyst to push more organizations toward value-based care? On the other hand, we're also hearing organizations say, we don't have time to deal with these value-based care initiatives, these quality initiatives. We're just treating patients as quick as we can, and we may not have the ability to invest in a new business model and setting up the infrastructure for that. So I'd be interested to hear your thoughts, which side of the fence you fall on here, Brian.
Yeah, it's a fascinating discussion because I've seen arguments all the way from value-based care is done for to value-based care will take over the world. So probably too early to tell off the bat. But it does seem that I agree with Ryota, the idea of cost shifting and the commercial payers subsidizing everyone else. Is that realistic moving forward? And really the fragility of the fee-for-service chassis as a vehicle moving forward. Even with value-based care, a lot of these models are built on fee-for-service. And is that sustainable long-term versus, as Kelly, you said, more global payment models, capitation, everybody thinks that smooth out the revenue and encourage, systems and providers to focus on wellness, prevention, public health versus, procedures and high utilization rates. The other interesting thing will be, the patients themselves, they're avoiding care right now. How much do they realize, oh, maybe I didn't need as much care as I had been consuming in the past? And what does that do to overall utilization? And does that change our dynamic nationally? And the third, the interesting thing, obviously the ACA is up for debate. It's scheduled to go to the Supreme Court later this year. If that would come down, that would open up and sort of clean the slate for the administration to think about alternatives to the current model. So lots of unknowns out there, but clearly this situation, the pandemic, has shown a light on some of our faults and things that we can improve on nationally.
Right. And my hope is that we can use this crisis as an opportunity to make structural changes for the better. Those organizations that can be strategically nimble are likely to see that advantage in their future financial position as well.
Absolutely.
Well, thank you, Brian and Ryota, for joining me today. I'm lucky enough to work with these two great minds on a daily basis, and it's been an honor to share with our listeners the insights that you're developing. If you like what you're hearing, please also listen and subscribe to our colleague, Dr. Tom Villanueva's Modern Practice podcast on Vizient's Medical Leadership channel. Tom discusses key healthcare trends through the clinical leadership lens. You can find it wherever you listen to podcasts. Thank you for listening, and stay healthy.
This has been another great episode of SG2 Perspectives, where industry experts and SG2 thought leaders explore the drivers of tomorrow's healthcare strategies to inform today's decision makers. Contact us anytime by sending an email to sg2perspectives@sg2.com. We'd love to hear from you. SG2 revolutionized healthcare demand forecasting with the Impact of Change forecast, and today, we're the industry's premier strategy advisory firm. To learn more, visit sg2.com. Thanks so much for listening, and we'll see you again soon.